Assalamu alaikum. Hope everyone's all right. Without any further delay, let's look into today's session. Today, we are going to have a discussion about two important case history. First important case history is that a 62 years old man is found to have confusion followed by coma. On further query, he has vertical gauge palsy. His son mentioned that it is of sudden onset, and there is CT scan done, which reveals actually no abnormality. So let's break it down. The patient is confused, followed by coma. So there is some central nervous system insult. Also, there is vertical gauge palsy. So there could be midbrain involvement because midbrain has the vertical gauge center. There is horizontal gauge center situated in the pons and the vertical gauge center situated in the midbrain. This is information number one. Information number two, the patient is confusion followed by coma. So there could be some involvement of, both cortical or reticular activating system, and it is of sudden onset. Whenever we're talking about sudden onset problem, the most likely the insult is vascular. Okay, we did CT scan and the CT scan reveals no abnormality. So what should we do next? So ideally in this condition, as there is sudden onset involvement, CT scan tends to normal. We want to exclude further insult or further abnormality by doing the MRI of brain. So what does the MRI of brain shows? It shows, as we can see, there is bilateral thalamic lesion. There is unilateral and there is bilateral thalamic involvement. Okay, so in DW there is some restriction. In ADC, if we check the ADC, there is, let's check the laser pointer, and there is restriction evidenced by hyperintranslation, and in ADC there is hypointranslation. So it's most likely bilateral thalamic lesion. So whenever we're talking about bilateral thalamic lesion of sudden onset, it's most likely stroke. So why there is simultaneously bilateral thalamic involvement? Is it possible? Is it possible? That is the question. Whenever that comes to our mind, we always think of a particular artery. That is the artery of Parcheron. What is artery of Parcheron? It is a single artery. As you can see, there is a single artery, but it's a variety. It will goes back to both thalamus. So it's a rare vascular variety where a single dominant thalamo-perforating artery which arises from one pion segment that bifurcates and support the both paramedian thalami. So the idea is that whenever we're having bilateral thalamic lesion, okay, and we're suspecting a sudden pathology, always remember artery of Parcheron can lead to this. Okay, because it's a rare variety where a single artery is going to supply the both thalamus. And it is there is certain difficulty to perceive this in CT scan. So better to do MRI to quantify this type of lesion. So as you can see, there is both artery, and the most likely this artery is going to supply the thalamus. But in artery of Parcheron, there is a single artery. It will bifurcate to such extent that it will going to supply the both thalamus. So that is the thing we should always remember. There is some other MRI as well. As you can see, there is some bilateral thalamic involvement. So there's some midbrain involvement. Okay, there is another sign called V sign, in particularly artery of Parcheron infarct, that can lead to the appearance of V sign in midbrain. But ideally, it will going to supply the both thalamus. Okay, so there's some issues regarding that we should remember. So normally the P1 segment that is come from the posterior cerebral artery, they give the perforator to ipsilateral thalamus, and other thalamus will get supply from another P1 segment of PCA. But in Parcheron variety, one common trunk supply the both paramedian thalami, and the occlusion of this common trunk and this Parcheron variety cause bilateral thalamic infarct. Okay, so if there is bilateral thalamic infarct, there could be associated some impairment of reticular activating system causing confusion, drowsiness, stupor, or even coma. There is some midbrain involvement causing vertical gauge palsy, and nevertheless, there is also some memory impairment as well. Okay, what will be the ideal treatment in this condition? We should give the patient IV thrombolysis within the therapeutic treatment window, and if there is a large occlusion, present. In that condition, the mechanical thrombectomy can be done. Because isolated artery of Percheron is a very small one, it's very difficult to get appreciated on CT scan, even through the angiography. Okay, because it's a very small branch, so there will be less efficacy if we want to do the mechanical thrombectomy. So let's check the case history too. The age is much more younger. A 31 years old male is found to have sudden onset weakness involving the right side of the body. Issue is that this is a young stroke. There's a lot of things to be considered in young stroke, which actually we don't see in particularly the old stroke. So the issue is that he neither smokes, never drinks, never have taken illicit medicine. He has hypertension or something like that. In case of acute stroke, that could be also associated with high blood pressure. So the blood pressure is 154/92. Examination reveals the power to be 3/5 in right arm and right leg. So most likely the patient is having sudden onset stroke involving the right side of the body. So there could be the lesion in the left side. Okay. But the issue is that it is young age. So whenever we're talking about the young age, we need to find the etiology of secondary stroke. So we did MRI at that period of time. Actually, I taken this thing from some website. So as you can see, there is a small lacunar infarct. Okay, it's a small lacunar infarct involving the left side of the cortex or internal capsule. Sorry, left side of the internal capsule, as you can see. So in this condition, we need to identify some causes. So one query, there is no family history of clot. That is very important to find out whether any thrombophilia or any clotting disorder that can be attributed to these types of stroke. Also, there is no features of connective disease, like there's no joint pain, oral ulceration, fever, weight loss. Okay, no feature compatible with paroxysmal nocturnal hemoglobinuria, like there is no morning dark urination. There's no family history of stroke. Very important. A certain disorders like the CADASIL or other disorder can have family history of stroke. Okay. So, but he did mention some, burning sensation in the both leg. That could be also attributed to diabetes, but there is no history of diabetes. Okay. Whenever we are getting some burning sensation with peripheral neuropathy, with frothy urination, we always think that whether the patient is having diabetic, peripheral neuropathy, and nephropathy present or not. But there is no history of diabetes. Okay. But there is history of hypohidrosis. Very important to be considered. So only thing we got from the history that there is some burning leg could be attributed to neuropathy. There's some frothy urination, most likely proteinuria, and there is hypohidrosis, so decreased amount of sweating. So all of these things can tie together to a certain amount of disease, that is the Fabry's disease. Okay, whenever we're thinking the Fabry disease, we should remember it can lead to stroke and ischemic heart disease in particularly young age. Okay, it's a X-linked recessive disorder or X-linked disorder. So the male will be much more commonly affected. So what do we want to do next? We want to do the genetic study and alpha galactosidase A enzyme activity to exclude these types of abnormality. So this is just constellations of feature. It's a X-linked lysosomal storage disease. There could be certain manifestation like acrohyperesthesia. There could be anhidrosis or hypohidrosis, very important. There could be sometimes some, clouding of the cornea, even corneal issues as well. There is some angiokeratoma of the skin. Sometimes it can be present. There could be proteinuria to microalbuminemia. They can lead to progressive CKD in case of kidney. And sometimes you not need to forget that the patient is having peripheral neuropathy. So these are the features that commonly occurred in case of Fabry's disease. There's a classic triad, acroparesthesia, including hypohidrosis and angiokeratomas. So these are the things we need to consider whenever we're going to solving this type of stroke related problem. Also, whenever we're going to do service or give service to the patient in the ward. So that's it from today's small session. Let me know in the comment section. Is there any further query you have regarding this topic and any other topic you want to get discussed in the future days? Stay healthy and safe. Assalamu alaikum.